So انتهى الانترودكشن. حكينا على البيزك نيورو اناتومي، النيوروفيسيولوجي، كيف يتكون النيرفس سيستم، organization of the nervous system. حكينا على انه الاورجنايزيشن اوف ذا نيرفس سيستم في anatomical organization اللي هو هذا مقسمه الى central وبريفرال، وفسيولوجيكال organization، وهذا يعتمد على الفانكشن of the nervous system. وكما حكينا ان النيرفس system it has many functions through many subsystems. It has the motor function through the motor system, the pyramidal system, or sensory system, sensation, and we have other systems. Now, from this lecture, we will discuss diseases of the nervous system. And we start with the common disorders. Very common one is the cerebrovascular disorder. Why it is very common? Because a lot of people have cerebrovascular disorder. This is number one. And the cerebrovascular disorder is related to the multiple internal diseases, internal medicine, like problem of hypertension. نتكلم على risk factors and controlled hypertension, or diabetes and controlled diabetes, or other, for example, smoking. So cerebrovascular disorder is very common, and it is related to the many diseases and many problems. Now, we start with the first slide. هذا السلايد حقيقة it represents the following. Now, we have and we have a stroke, TBA. Now, this area, there are neurons. The neuron in that area, when there is a stroke, the blood vessels, the blood supply stop. So get ischemic, for example. So they are asking for help. They are asking for help. So there is relation between the time of occurrence of the stroke and the time of starting treatment. The quicker you treat the patient, probably these cells could have a return of blood flow and come back to normal. But if you delay it, these cells might be left with permanent disability. Now, we start the stroke, and the stroke is like the heart attack. It is a brain attack. In the heart attack, we have part of the muscles of the heart is getting ischemic. Same thing here. Couples of neurons get ischemic. So, being attacked. Stroke. And the stroke classically divided into number one, ischemic or hemorrhagic. And the ischemic means that there is little or no blood is going to that area. So that's why that area gets ischemia. And it is the majority of the stroke are ischemic stroke. about 84%. And why ischemic? Either thrombotic or embolic. Thrombotic means that the blood vessel itself, blood vessel wall is unhealthy, and there is thickening of the blood vessel wall, and that thickening causes narrowing of the lumen of the blood vessel. And when there is narrowing of the lumen of the blood vessel, the blood flow getting slow. And when the blood flow getting slow, the blood tends to clot and block the blood flow completely. This is called thrombotic. هتكلم عليها بعدين بالديتيل. Or the ischemia due to embolic. Embolic means some emboli coming from outside the brain circulation. For example, coming from the heart, emboli. Going through the circulation, going to the cerebral circulation, and block one blood vessel. And when that blood vessel is blocked, there will be ischemia. And that's why we have the ischemic stroke, 84%. So that causes stroke. Or the stroke is due to hemorrhage, called hemorrhagic stroke. Hemorrhagic stroke, it is less, 16%. And in hemorrhagic stroke, there is a blood vessel, there is a aneurysm in the blood vessels, and that blood vessels rupture. And the blood escape outside the blood vessel. It goes to the nerve substance, to the cerebral substance, free blood, and that will cause death of the neuron. That's hemorrhagic stroke. So we have ischemic and hemorrhagic. And as we said, ischemia by inadequate blood flow. Now, occur when ischemia to part of the brain result in the death of the brain cells. Now these are variety or types of stroke. We start the type of stroke. We have the ischemic stroke اللي حكينا بها هي about 84% ischemic stroke. And in the ischemic stroke, we said it is of two types, either the thrombotic or embolic, 84%. And it's caused by blood clot. The hemorrhagic rupture of blood vessel. We have another entity called transient ischemic attack, or the other name for it is mini stroke. Mini stroke. And in the mini stroke, caused by a very short time, temporary blood clot. Block the blood vessels in a very short period of time, and then that clot dislodged and go away. And the blood come back again, and the neuron recovered before the death. هنتكلم عليها in detail. So, as we said, that the ischemic stroke, we have the thrombotic stroke and the embolic stroke. And thrombotic stroke, we have diseased blood vessel, look, atherosclerosis, and the blood very slow, and that leads to clot. And this is called thrombotic stroke. The embolic stroke, we have embolus coming from outside and coming there to the brain and block blood vessel. On the other hand, the hemorrhagic stroke, there's a blood vessel there and rupture. And the blood, when vessel rupture, the blood goes outside. For example, aneurysm rupture. And that's a free blood. And that free blood will kill the cells. So this is the ischemic thrombus, ischemia, or hemorrhage rupture. Same thing. This is the blood flow block, obstructed, causing thrombotic stroke ischemia, and this is hemorrhagic stroke rupture. Okay. Now, what are the clinical presentation of a stroke?
سؤال انه اكثر الثرومبوتيك ولا الامبوليك؟
هسه هتكلم عليها ان ديتيل. اصبر هسه. Now, the clinical manifestation, it depends, number one, on the site, whereabouts. For example, stroke in the anterior part of the cerebral cortex, or stroke in the middle part of the cerebral cortex, or stroke in the posterior part of the cerebral cortex. Site. And size, small area or large area. And certainly, large area will affect more than small area. So site and site. And the presentation could be a motor area leading to weakness, motor symptoms, or sensory, or emotion. And as I said, the loss of function varies with localization and extent. This is the circulation of the brain, and usually the blood supply to the brain through two sources. We have the anterior circulation from the carotid artery, giving the internal carotid artery, give the middle cerebral artery, and we have the anterior cerebral artery and communicating artery. We have the vertebral artery, posterior circulation from the basilar artery, and the basilar artery divided to posterior cerebral artery and communicating artery, and this is the circle of Willis. These are the basilar artery. So we have anterior circulation and posterior circulation. Now, there are common signs and symptoms which everybody should be aware about it, whether doctors or non-doctors. But you are as a doctor, for example, and you are in the outpatient, the stroke come in a variety of presentation. For example, the patient could be presented, he came and said, there is numbness or weakness in the face, arm, or leg, okay, especially on one side of the body. This is one presentation. The other presentation, elderly, all of a suddenly become confusion, and the speaking is become troublesome, okay? And you cannot understand his speech. Or all of a sudden, vision problem, trouble with seeing on one side, or trouble with walking, or sometimes, especially in hemorrhagic stroke, with severe hypertension, there is severe headache. So these are common signs and symptoms. Now, these are the ischemic stroke, and these are the common signs and symptoms. For example, facial dropping, arm or leg weakness, or slurred speech, or balance, or vision, or headache because of this thing. Now, what are the risk factors? This is very important. We divide the risk factors into two categories: modifiable or non-modifiable. Non-modifiable, you can not change it. For example, age. Stroke is more common with advanced age because of advanced atherosclerosis and presence of comorbidity like hypertension or diabetes. Gender, male and female, but women with stroke likely to mortality is more than male. Race, African race, or hereditary problem. This is the non-modified, okay, or risk factor. The modifiable risk factor, which is very important, especially for prevention. For example, patient with asymptomatic carotid stenosis, patient has the atherosclerosis of the carotid artery, and because of the carotid artery atherosclerosis, there is narrowing of the blood vessels, and some of the atherosclerosis area, small area, dislodged and goes up and causing embolic stroke. Diabetes, heart disease, especially with arrhythmias, atrial fibrillation. This is in the embolic stroke. For hyperlipidemia, hypertension, overweight and obesity, and contraceptive pills, another risk factor. Certain blood diseases like sickle cell disease, because sickle cell disease associated with abnormal blood vessels, abnormal RBCs, which could block a blood vessel. And this is common cause of stroke in young. One of the causes of stroke in young is sickle cell disease. While there is sickler, you has a stroke. And of course, smoking, risk factor. To many disease, and CVA is not exception. Okay. Now, this is a cross section of a stroke area. The stroke area has two parts, central part and peripheral part. The central part, or the core part, is dense area, where ischemia started early. The peripheral part, there is relative ischemia. The cells are still viable, still alive. This is called pneumobra. And it is very important here because this is the dense ischemia, and this is relative ischemia. We have to pick the patient as soon as possible so we can treat the patient so the pneumobra or the still relative ischemia get back to normal. And now these are sections shows the time occurrence of a stroke. For example, in 0 time, we have central area and peripheral pneumobra. The pneumobra is very large. Like if there is a delay in hours, the central core getting larger, more cells are dead, and the pneumobra getting thinner and thinner. If the patient is delayed in days, not in hours, here the central core is very large dead, and the pneumobra is very thin. So it is very important to catch the patient as soon as possible. This is very, very important. Okay. Now, what is the pathophysiology? The pathophysiology is very easy because we know that the brain cell depends and need continuous supply of oxygen and glucose. When there's interruptions of blood flow, there's interruption of the oxygen and interruption of the glucose. And if the blood flow is interrupted early on, in the first half a minute and 30 seconds, the metabolism is changed, altered. This is in the pneumobra. Not dead, but metabolism is changed. If we cut the patient at this stage, we can reverse. Like if we pass the time in minutes, more than 2 minutes, the metabolism stop altogether. And in 5 minutes, the cell die, cell death. So change in the metabolism, stop of the metabolism, and cell death. And this is give you the time and the changes which happen. For example, in second, minute, or hour. And this is the number of synapses, number of cells. So it is like, this is the brain, and this is the time, and as the time goes by, the brain is losing more and more of its brain tissue with time. Okay, this is the unhealthy blood vessel, and these are unhealthy atherosclerotic changes which predispose to a stroke. Okay, so we go back that, as we said, there is the central area and there's peripheral area, and the around the core area there is ischemic area, border zone, and this is potentially reversible. So there is moderate ischemia, delayed ischemia. In the core area there is dense ischemia or early infarction. So if adequate blood flow restored, less than 3 hours, ischemic cascade could be stopped and less brain damage happen. And this is very, very important. ولهذا الآن يعني management of stroke changed recently. Management of stroke change. For example, the patient or the family dial 911 and they have a stroke patient, immediately you go to the patient. And in certain countries, even there is a mobile CT scan to detect the stroke as quick as possible. Okay. This is the center area, and this is the peripheral area. And now we are working on this area. We have to salvage and treat this area as soon as possible. Okay. راح نتكلم على التايب اوف ستروك، نتكلم على TIA، نتكلم على thrombotic stroke، نتكلم على embolic stroke، ونتكلم على التايب والبرسنتج مالها، كم بالامبوليك وكم بالترومبوليك، راح نتكلم عليها الآن. Okay. Now we start with the TIA or transient ischemic attack or mini stroke. And by definition, there is temporary focal loss. Okay? For example, weakness, hemiparesis for a short period of time and then improve. Or sensory changes, or visual, blurring of vision for a short period of time and come back to normal. There is a blockage, and the blockage is dissolved very short period of time and before the complete death of the brain cells. It could be motor, sensory, or visual, and caused, of course, by ischemia. It is similar to the angina, with cardiovascular problem. The angina just pain, no death, and could be improved. Same thing here. Now, most of them resolve within 3 hours, and the mechanism could be a microembolus that temporarily block the blood flow. Like a very important TIA, it's a warning sign, indicate a progressive cerebrovascular disease, unhealthy cerebrovascular disease. وهذا مهم جدا. هذا احنا نشوفه من يجي المريض عنده ترانزيانت هيميباريسيس بصير كويس زين. يقول لك يا دكتور انا بدي اروح الدار. الحمد لله جلطة عابرة، هذا بالتعريف العام. عبرت الجلطة راحت. يقول لي لا، هي صح جلطة عابرة، بس هالمرة عابرة، مرة ثانية ما تكون عابرة، تكون ثابتة. ليش؟ يقول لك ليش يا دكتور؟ قل له this is indicate انه أوعية دموية pure blood vessels in the brain is unhealthy and liable for complication. هالمرة سلمت الجرة، مرة ثانية لا، يمكن يصير permanent or death. فأنت شو أعمل يا دكتور؟ you have to work on your risk factors. شو عندك؟ hypertension، diabetes، carotid stenosis، heart cardiac arrhythmias، overweight، smoking وقف. إذن هي a warning sign. When you do a scan, there is no sign of acute infarction on the brain image. So this is the embolus block for a short period of time and then goes away. This is transient ischemic attack. بينما هنا permanent blockage. Okay. So it is a stroke is emergency. And في عندنا هنا term called be fast. كن سريع. والبي فاست بها معاني حسب الكلمات الأحرف الموجودة. البي patient could lose balance، شوف unbalance. والإي for the eye vision problem visual problem. والإف facial asymmetry. والA arm or leg weakness. والS speech slurring of the speech. And you have immediately you have to check the time. So be fast. Okay. هاي معادة نفس الشيء type of stroke. هنا نجي على الجواب على سألني كم البرسنتج مع الامبوليك والثرومبوتيك. هنا الاسكيميك stroke we have thrombotic and we have embolic. تقريبا الثرومبوتيك هي 35% والامبوليك اقل 30%. فكذا تطلع تقريبا 64%. يبقى عندنا شو؟ يبقى عندنا 20% لاكيونار هتكلم عنه. الثرومبوتيك ستروك اللي هي اول اللي هي 35% usually occur during rest. For example, patients goes to sleep 10 o'clock in the night, wake up in the morning, with a stroke. So during sleep. And due to what? The perfusion failure of the blood flow because of severe stenosis and sometimes occlusion of the major blood vessel. And the presentation is very, very slow. Gradual, but progressive. On the other hand, the embolic one, the embolic stroke, the 30%, most of the time occur while the patient is awake. And the problem is due to embolus from cardiac source. And the presentation is sudden, not slow, sudden, immediate deficit, and sometimes associated with seizure. And then هذا الثرومبوتيك وهذا الامبوليك. عندنا واحد هو اللاكيونر انفاق. هذا اللاكيونر انفاق. باللاكيونر انفاق هو problem with the small blood vessels. هاي هي is small blood vessel. This is a lacuna. And the small blood vessels are affected, mainly affecting the basal ganglia. And head area high, موجودة basal ganglia. For example, it affects the putamen, or it affects the pons, thalamus, caudate, or sometimes internal capsule. The presentation is abrupt, sudden, or could be gradual. إذن هذول هم التايب of the embolic, thrombotic lacunar. والlacunar or problem with the blood vessel wall itself. There is hypohydrosis, destruction of the blood vessels. Okay. هاي طبعا demonstrate the thrombotic stroke. This is atherosclerosis, slow blood. This is the embolic stroke, and this is the hemorrhagic stroke. This is the ischemic hemorrhagic stroke. This is the ischemic stroke. If you do a scan, you find that black, hypodense, ischemic stroke. White, hyperdense, hemorrhagic stroke. هذا الفرق بين ischemic والhemorrhagic stroke. Same thing. Ischemic stroke, hemorrhagic stroke. Hypodense, hyperdense. Okay. So, as we said, that the ischemic stroke, as we said, result of inadequate blood flow due to partial or complete occlusion, and it's about 85%. طبعا, most of the patients with ischemic stroke do not have decreased level of consciousness, especially in the first 24 hours. Like sometimes the symptom getting worse during the coming 72 hours due to the cerebral edema. This is called stroke and evolution. وهذا هنا يجي على شكل سؤال. يعني يقول لك patient came with ischemic stroke, hemiplegia, and he was conscious. But after 1 or 2 days while in hospital, his condition is deteriorate. His consciousness disturbed, become drowsy, or even coma. And that indicates a complicated stroke. Mean that the stroke is get complicated. And one of the complications of the stroke, the development of edema around the stroke. And when there is edema around the stroke, that will increase the size of the stroke and lead to raised intracranial pressure and could lead to midline shift. And that's why the patient lost consciousness. And this is called stroke in evolution. This is called stroke in evolution. Complicated stroke. That's why later on, after 3 or 4 days, development of edema and patient lost his consciousness. Now, the CT scan, sometimes patient came with hemiplegia. You do a CT scan and tend to be normal. So sometime early on, the CT could be normal. You have to repeat it again in a few hours. 6 hours, 8 hours, 10 hours. Then the hypodense area appears. فلهذا المريض يمكن أهل المريض يقول لك خلاص دكتور الصورة الطبقية مالتها نورمال طبيعية، ليش نبقي المريض في المستشفى؟ ناخذ الدواء؟ لا، بدنا نعيد الصورة مرة ثانية لأن الصورة قد تكون normal early on. It needs some time to develop. So a normal CT scan does not exclude a stroke. وهذا يجي من multiple choice questions. طبعا الاريا اوف ستروك تعتمد على البلاد vessels. The blood vessel could be in the anteriorly between the anterior cerebral artery and middle cerebral artery, or between the middle cerebral artery and lateral cerebral artery, or posteriorly between middle cerebral artery and posterior cerebral artery. Okay. Now, as we said, the ischemic stroke, we have the thrombotic stroke, usually related to a diseased blood vessel due to deposition of the lipid deposition and atherosclerosis. Other number one. So there is a result of thrombosis due to narrowing of the blood vessel. It is the common cause of a stroke. This is diseased blood vessel, atherosclerosis, and the blood clot there. Now, 2/3 of the thrombotic stroke associated with hypertension and diabetes. وهذه يجي في multiple choice question. 2/3. And often preceded by the TIA. لأن TIA indicate unhealthy blood vessel. هذا خدناه. Now this is a diagram for the ischemic stroke, facial dropping, and these are the area MCA, PCA, and ACA. And this is the B fast. حكينا عليها. Okay. The embolic stroke, on the other hand, okay, majority the embolus originate in the heart. Okay, and because in the heart, especially post myocardial infarction, there is area of the heart is infarcted. So part of the myocardium is infarcted. And that part of the myocardium, because it's infarction, becomes static, massive contraction. And then the blood, which is against that infarcted area, get clot. And part of that clot could dislodge and goes up and causing embolic stroke. So in the heart, breaking down of the endocardium goes to the circulation. It is associated with very sudden, rapid occurrence of severe clinical symptoms. So this is the thrombotic, this is the embolic. So this is the heart, this is the problem, this is AF. Here we have thrombus, and that goes up and block. Go through blood vessels there, because of embolic. Okay. And patient usually remain conscious, okay, but could have a severe headache. And recurrence is common, unless underlying cause is treated. Okay. What about the hemorrhagic stroke? The hemorrhagic stroke, on the other hand, it is about 15% less. And the bleeding resulted from bleeding, rupture of blood vessels, either in the brain tissue itself. This is called intracerebral hemorrhage. Okay? Or the bleeding in the subarachnoid space, this subarachnoid hemorrhage. راح تاخذوها in detail in neurosurgeon. Or the bleeding in the ventricle, intraventricular hemorrhage. So either ICH, intracerebral, or SIH, subarachnoid, or IVH, ventricle. Or sometimes the ICH in the cerebral cortex, blood will go to the ventricle, lead to IVH. So an ICH plus IVH, which is serious complication. So it's the hemorrhage, hypertension. Okay. Now, the bleeding, because of rupture of blood vessel and associated with uncontrolled hypertension, which is with ICH, and occur during activity. وهنا it is associated with silent hypertension. وناس كثيرة يجي patient cerebral hemorrhage blood pressure يشوفه 200 over 130. تسأله did you have hypertension? He said no. طبعا. Then silent killer. Hypertension is a silent killer. القاتل الصامت. The first presentation يمكن هو عمره ما بشيك حاله، عمره ما قايس البلد بريشر، بس يجي with complication. يجي with serious stroke. Hemorrhagic stroke is more serious because mortality and morbidity in hemorrhagic stroke is more than ischemic stroke. So this is the hemorrhagic stroke, and this is intracerebral ICH, global hemorrhage, or subarachnoid hemorrhage. Subarachnoid hemorrhage. Intraparenchymal lobular hemorrhage. This is the blood vessel, this is the aneurysm, and that rupture. And that has the difference between ischemic and hemorrhagic. The low Glasgow Coma scale. The patient, they lose consciousness early. And sometimes you need to do decompression. Okay. The ICH often occurs sudden onset of symptom, and they progress over time, over a few minutes sometimes, especially if the hemorrhage is continuing. Now, the manifestation of hemorrhagic stroke are the following. Number one, neurological deficit, neurological sign, like hemiplegia. Number one. Number two, sometimes severe headache. Severe headache because uncontrolled hypertension. Number three, commonly associated with decreased level of consciousness. And number four, associated with uncontrolled hypertension. هاي الأربع أشياء character of hemorrhagic stroke. تيجي على شكل multiple choice question. يمكن يخلي لك هاي the following are true about cerebral hemorrhage except one. ويخلي لك هاي بعدين الدي يخلي لك بدل ما يقول uncontrolled hypertension يقول controlled hypertension. هذا طبعا wrong راح يصير. This is the aneurysm rupture causing cerebral hemorrhage. On the other hand, the subarachnoid hemorrhage وراح تاخذوا يمكن more detail in neurosurgery. The rupture of blood vessels could be in the have two types. Either still we have in the hemorrhagic stroke, either in the subarachnoid space, that's subarachnoid hemorrhage, about 41% of the cerebral hemorrhage. So subarachnoid hemorrhage. And the bleeding into the subarachnoid space. Or as I said, the hemorrhage would be cerebral hemorrhage, intracerebral be 59%. This is 59 or 41, either from the 15%. And this is due to spontaneous bleeding in the cerebral cortex. The subarachnoid hemorrhage from the name is bleeding in the cerebrospinal space between the arachnoid and pia mater, commonly due rupture of cerebral aneurysm. This is the subarachnoid. Okay. So finally, what are the clinical manifestation of a stroke in general? We could have problem with the motor function. And the motor function manifestation of any stroke could be presented in the following. We could have impairment of mobility, hemiplegia, or paralysis of the respiratory muscle, respiratory failure, respiratory function, or problem with the muscle of the esophagus, swallowing problem, or speech problem, and gag reflex. And this is very important. Any patient with stroke, you check for gag reflex. By tongue depressor, you touch the pharyngeal wall, and this should be, there is movement. If the gag reflex is absent, very important, you should not give the patient anything by mouth. And also, you have to instruct the family not to give the patient any drink, juice or water, nothing by mouth. You put nasogastric tube and you put the venous access. Gag reflex. Also, the patient self-care, he cannot look after himself, and the patient will lose the skill voluntary movement. And of course, طبعا التون changes in the reflexes. Okay. Now these are comparison between two types of stroke, two areas. One is stroke on the right side, right cerebral hemisphere, right. من تحصيل حاصل, so the stroke will be on the right side of the brain. There will be paralysis of the left side of the brain, hemiplegia. And the patient could have left side neglect. Sometimes we neglect his left side. كيف neglect left side? يعني البيشنت, you sit the patient, or the patient is lying in the bed and he's closing his eyes. And he had a right stroke, so left side hemiplegia. So the left side hemiplegia, the patient closing his eye, you stimulate the right side, his head right. You stimulate the left side, his head left. You stimulate both, you will feel only one side, and the other side will neglect. That's why this is minus the left side neglect. هذا هو التفسير. أيضا the patient, the right side stroke, beside the paralysis and the left side neglect, the spatial perception deficit أقدر يفرق وtry to deny or minimize as a problem. طبعا the rapid performance could be impaired, language could be impaired, and impaired of judgment important. and time perception. On the other hand, if you have a stroke of the left stroke, left cerebral cortex, that's at the right side hemisphere. So paralysis on the left side, on the right side. And now actually impairment of speech and language. Okay? And also the performance of the patient is very slow. But the patient is aware of this deficit. Not be denied. But there is impairment of comprehension. Other part on the left side. Okay. So the clinical feature in general, we have thrombotic stroke, often preceded by TI in the safe distribution. Embolic stroke, usually sudden, abrupt, occur without warning. And the common source is heart, arterial fibrillation, or valvular agitation, endocarditis, or rheumatic heart disease. Hemorrhagic stroke, largely due to hypertension. And the deficit is more diffuse and widespread. هتيجي على شكل multiple choice question. Okay, so the clinical manifestation, we said the motor changes, sensory changes, intellectual changes. حكينا عن الموتر والsensory, but the spatial perception alteration هذا راح أتكلم عليه. وأيضا عندنا personality changes will affect the mood, affection, sensations, and communication. Now, حكينا على الموتر presentation بالstroke والموتر manifestation حكينا عليها mobility, respiratory, swallowing, gag reflex. Now, the motor deficit usually is contralateral. The patient loses skill voluntary movement and the impairment of integration movement. And usually patient with stroke, early on, paralyzed side, there is alterations of muscle tone. شوف أول يوم the muscle is flaccid, flaccidity. لكن بعدين after the 24 hours يصير spastic. فلا تستغرب إنه مريض hemiplegia in acute phase in the flaccid. إنه بعدين يصير spastic. So change from high reflexes also early on could be hyporeflexia and later hyperreflexia. Communication, yes, could be affected. Patient could be aphasic, and by the aphasia, total comprehension and use of language impaired. لا بيفهم ولا بيتكلم. لكن could have dysphasia, but dysphasia could be motor, expressive, or sensory, receptive. Expressive motor dysphasia, he understands, but he cannot talk. ممكن يجاوب كتابة. Receptive dysphasia sensory ما بيفهم. الجواب مالته يكون unrelated to the question. هذا هو الفرق بين الديسفيزيا والافيزيا. ها راح تجون الكلينيكال راح نعمل ديمونستريشن كامل عليها. Articulation problem, dysarthria, yes. And this is because of disturbances of the muscle control of the speech. So the pronunciation and articulation and phonation will be affected. But the meaning of comprehension remains the same. In affection, sometimes patients have difficulty of control their emotions. There is emotional response, exaggeration. For example, the patient, all of a sudden, if you talk with him, they cry easily or they laugh easily. And this is especially with multiple stroke, multiple small stroke. This is called pseudobulbar palsy. ليه يسموها pseudo bulbar palsy characterized by dysphasia, dysarthria, emotional lack. ليش؟ لأنه اترك السودو بالبلبر بالزي إذا كان بروبلم بالبرين ستيم there is dysphasia and dysarthria لكن ما في emotional liability. فإذا صار emotional liability indicate it is not in the brain stem, it is supra, over, in the bilateral cerebral infarction called pseudo-bulbar palsy. نشوف شغلة بعدين
Yes.
Okay, so this is the pseudo-bulbar and bulbar. Patient could be depressed. Less depressed. The patient, one time his everything is okay. But next morning he cannot move. He cannot talk. Of course you get depressed. So depression in terms of body image. Okay? Patient is frustrated. There's mobility problem, communication problem. Okay. Now, هنا نعالج عليها spatial perception alteration. إن إذا كان stroke on the right side, the patient causing problem with spatial perception orientation. يعني أكو neglect. إذا كان right side, you will neglect the other side. The right side stroke, you neglect the left side. If you stimulate each side separately, you will feel it. If you stimulate both sides at the same time, you will feel only one side. What are the diagnosis? Investigation. Diagnostic study and investigation are the following. Number one, you have to confirm that the ability is a stroke, not something else. And a patient into a coma. Muda and stroke. The other causes of coma could be metabolic coma and diabetes. So you have to exclude other causes before you decide this is a stroke. The first thing to confirm that disability is a stroke and not due to something else. Number two, to identify the type of stroke, to differentiate between ischemic stroke and hemorrhagic stroke. Differentiate between ischemic stroke and hemorrhagic stroke, and this is especially by the CT scan. The ischemic stroke is hypodense, black, and the hemorrhagic stroke is white. But sometimes the ischemic stroke early on could be normal. CT scan could be normal. Also, you have to do what we call it stroke workup. A stroke workup, you do a general blood test.
Blood sugar,
Blood urea,
polycythemia.
anemia, all these are predisposing factors. You do a CT scan, okay, that could be normal early in the ischemic stroke. But you can, the CT scan differentiate between a ischemic stroke and hemorrhagic stroke. Later on, we do more investigations, like for example, you do the MRI scan or the MRA scan. Of course, we should not forget to do a carotid ultrasound to detect any atherosclerosis, or you do a cardiac echocardiogram, especially an embolic stroke. These are investigations. هذا CT scan could be early normal later on. Okay. Prevention. The prevention هو education and management of the risk factor اللي حكينا عليها to prevent the risk factors, modifiable risk factors. So you have to have a close management of patient with a risk factor. Okay. So what are the prevention? The prevention خليناها A, B, C, D. شو هي ال A, B, C, D? ال A, especially with ischemic stroke, we use the anti-thrombotic agents like aspirin, or dipyridamole, or both, dipyridamole and aspirin. Okay, well, dipyridamole will Plavix. Either use Plavix or aspirin or both in ischemic stroke. The anticoagulant, there is no role for anticoagulant in the ischemic stroke except an ischemic stroke due to embolism, that's embolic stroke, with a known site of embolization, like cardiac source with arrhythmias. Here you might think of using anticoagulant. Otherwise, use only antiplatelet. So anticoagulant, دائما بالأورال بنصير دائما يقولون anticoagulant. Anticoagulant not always used. Anticoagulant used only in the embolic stroke with a source of embolization. Okay, so that's A. The B, of course, blood pressure control. The C, lipid, hyperlipidemia, and cholesterol lowering medication, or carotid revascularization. Okay. And D, diabetes control. Also, the prevention, the antiplatelets are usually aspirin to prevent stroke in those patients. The disease, carotid artery, sometimes there are certain surgical intervention. And that surgical intervention, especially for atherosclerosis and the carotid artery. But there are different techniques. For example, there's the carotid endarterectomy, removing the atherosclerosis, or transilluminal angioplasty, or stenting. Lekin, it depends. It depends on the degree of the stenosis. If it is very mild degree of stenosis, less than 20, we do nothing. If it is very severe, 70 and 80%, now you have to be very cautious because you might precipitate more when you do intervention, you might lead to further embolization. And then very low 20% ما نعمل شيء والفيري هاي، لكن تبقى عندنا هاي 40% إلى 60% يمكن نعملها هاي التكنيك. قاعد يتكلمون عليها النورو سيرجري كثير عليها هاي. اوكي هذا خلاص. هنا الاكيوت كير، انت بالطوارئ وجاك بيشنت وستروك، انت كطبيب بالطوارئ حالك موجود وانت بنص الليل هيجيك بيشنت وذ ستروك، شو هي الفيرست ايد؟
Glasgow scale.
First aid. The following. Number one, when the patient comes, first thing to assess the level of consciousness. حسب Glasgow Coma scale. ليش؟ There is a table and you put the level of consciousness. And that level of consciousness could change, could improve or could deteriorate. وانت مو لحالك ال 24 ساعة موجود بالطوارئ، يمكن يجي طبيب بعدك يشوف الشارت ويشوف الليفل اوف consciousness ويقارن بالليفل اوف consciousness later on ويشوف if there is deterioration or there is improvement. And then assessment of level of consciousness, and you have to put it in a table. Glasgow Coma scale. Number one. Number two, you demonstrate the weakness with ثبتها, numbness, and paralysis. Also, you assess the speech and visual disturbances. If the patient has a severe headache or have arrhythmias, or the patient have respiratory problem and respiratory paralysis, or the patient have unequal pupil, especially if there is raised intracranial pressure. هاي كلها تثبتها أول ما يدخل البيشنت، ما تاخذ منها كثير. Also, you assess the blood pressure, hypertension, and also you assess if there is any facial dropping on the affected side. Very important, you assess if there is any difficulty of swallowing to avoid inhalation by checking the gag reflex. لأنه إذا كان gag reflex negative وأهل المريض يعطوه fluid أو يعطوه whatever it is, هذا will go to the lung and causing pneumonia, which is difficult to treat. Most of the patients with stroke will not die from the stroke, will die from inhalation pneumonia, which is very severe to treat. Some of the patients develop seizures, about 10 to 15%. You have to treat that. Bladder, patient could be incontinence or retention or bowel, nausea or vomiting or whatever. كلها يؤثر. أيضا you do the initial AB تعملها تسحب investigation, and you have to be very sure about patent airway. The patient ما عنده difficulty in breathing. Also remove any dentures. هذول الأسنان الاصطناعية ترفعهم عشان لا يصير inhalation. وتعمل oximetry, pulse oximetry. و maintain adequate oxygenation, IV access, and maintain blood pressure normal. I could have first aid. Also, the patient, you do immediate CT scan to differentiate between ischemic and hemorrhagic. And you do certain measure to control intracranial pressure. Usually, the head and neck alignment. Avoid neck flexion. And elevate the head about 30 degrees if no symptomatic shock present. Avoid hip flexion or knee flexion. And pain management. High scan between ischemic and hemorrhagic. Also, in the acute care intervention, you have, if there is any seizure, sometimes you have to give anti-seizure treatment. Avoid hyperthermia, لأنه الهايبرثرميا increase cerebral metabolism. وهذا نشوفه المريض عنده stroke وأهل المريض يجوا put many blanket on him, and this many blanket causing hyperthermia, and hyperthermia will increase the metabolism of the cerebral cortex. He already, there is deficiency in the metabolism. وانت سوف تعمل hyperthermia ما بيصير. وأيضا you think of thrombolytic or fibrinolytic therapy. وهنا هاي for the fibrinolytic اكو فرق بين الانتي بليتلتس واكو فرق بين thrombolytic. Thrombolytic means dissolving of the thrombus. وهنا thrombolytic criteria, it has certain characters. Number one, the patient should be treated as early as possible, within first few hours. Number two, you have to differentiate between ischemic and hemorrhagic. You do initial CT scan. If the initial CT scan show ischemic stroke, that the patient is candidate for thrombolytic drug. If the CT scan showed hemorrhage, there is no thrombolytic drugs. Okay, so you think about thrombolytic drugs. And this is according to the thrombolytic protocol. And this is the drugs given through a catheter. And you give the drug, thrombolytic drugs, and that called tissue plasminogen activator, TPA. And that TPA, through a catheter, you go to the clot and you directly, through a catheter, and that could dissolve the clot. And many patients, when that maneuver is done, the patient could recover completely. That's why بداية السلايدات كتبت time loss is brain loss. كلمات you catch the patient as early as possible, the patient could use this thrombolytic drug. So the early as 4.5 minutes. طبعا sometimes there is طبعا هذا will decrease disability, لكن sometimes there are complications, increase death by, especially in the 7 to 10 days, because sometimes associated with intracerebral hemorrhage. Okay. Also, for ischemic stroke in the first 24 hours, TPA, we use the antiplatelet and anticoagulant. نعمل TPA بعدين نعطيهم antiplatelet or anticoagulant to prevent further. The antiplatelet or anticoagulant will not treat the thrombus, but to prevent further. لكن to treat the thrombus itself was thrombolytic. Okay. And of course you have to monitor vital signs, our level of consciousness, motor, pupil size, oxygen count. Seizure, approximately 10 to 15% patients could develop seizure with stroke, so that's especially in the first 24 hours. That's why sometimes we use anti-seizure medication. Now, surgical intervention, sometimes we think about it, especially in a very large hemorrhage. And this is need to ask the neurosurgeon for immediate evacuation of a large hematoma, okay, resulting from hemorrhage, hemorrhagic stroke. Could lead to midline shift. Or in subarachnoid hemorrhage also, you need the help of the neurosurgeon. Either you clip the neck of the aneurysm, or you wrap the neck, or you coil the aneurysm itself to prevent further bleeding. Now, finally, the rehabilitation. So after the patient have stabilized the patient in 12 to 24 hours, then you do the rehabilitation for preservation and to decrease the disability. هذا هو آخر شيء. Thank you.
Welcome.